Hi, good morning, everyone. Good morning. Seeing everyone coming in. Just waiting on one presenter, and we will begin shortly as soon as the presenter gets in. Just having a bit of connection issues. Right, so thank you so much. Good morning, everyone, and welcome. Welcome to the Multiple Sclerosis Support Foundation celebration of World MS Day 2021. I just want to give special morning greetings to Dr. Avidesh Panday. He's a neurologist and representative from the Ministry of Health. Dr. Daphne Phillips, our president and founder of the Multiple Sclerosis Support Foundation. Board members of the Multiple Sclerosis Support Foundation, Mr. Tiba Phillips, Mr. Hesmond Grant, our specially invited guest and featured presenter this morning, Dr. Nicholas Maraj, other specially invited guests, the Foundation's membership, our MS warriors, stakeholders, friends, and well-wishers. Thank you. Good morning to everyone. My name is Saron Bailey. I'm the newest addition to the Multiple Sclerosis Support Foundation. Very happy to be here and serve in the fight against MS. And I will be your MC for the next hour and 15 minutes. Right, so we're going to hear from Dr. Avidesh Panday, who is representing the Honorable Minister this morning. He sends his apologies. He's unable to be with us. Something very important came up. So he will deliver our feature address. We will hear from Dr. Daphne Phillips, who will give opening remarks. And of course, our featured presenter, Dr. Nicholas Maraj, who is a esteemed neurologist with significant experience working with persons with MS and in the MS field. Sorry about that. So without further ado, let's get the ball rolling, and I will invite Mr. Hesmond Grant to kick things off with the opening prayer.
Good morning. Our prayer today is that your will be done through this event. Take what we have prepared and multiply our efforts as only you can. Stay our intentions to align with your righteous will. Remind us that your faithful provision, when our efforts fail us or fall short. May all glory go up to you when we reach the finish line and climb over the benchmarks. Blanket us with your peace today. Father, keep us physically safe and guard our hearts and minds from pride and selfishness. Keep love at the forefront of our minds today and your guiding light for all we set out to accomplish in our celebrations. With this we ask you through Jesus Christ our Lord. Amen.
Amen. And now call on Dr. Daphne Phillips, our president, to deliver opening remarks.
She's on mute.
We can't unmute her.
Hello?
We can hear you now. Sorry.
Okay, good morning. Welcome to everybody. Warm regards and welcome on this very wet and cold day in Trinidad and Tobago. I am the president of the MSSF. My name is Dr. Daphne Phillips. So, to Dr. Avidesh Panday, consultant neurologist at Eric Williams Medical Sciences Complex, who is representing the Honorable Minister of Health, Mr. Terence Diyal Singh, and he will give the feature, the address from the Minister of Health. We also like to welcome Dr. Nicholas Maraj, who's a consultant neurologist with the Eric Williams Medical Sciences Complex, as well as our directors of the board of MSSF, Mr. Tiba Phillips and Hesmond Grant, members of the foundation, the Multiple Sclerosis Support Foundation, who are my fellow MS patients, specially invited guests, stakeholders, and well-wishers. Thank you for accepting our invitation to celebrate World MS Day with us today. World MS Day is usually celebrated on the 30th of May every year, but in Trinidad and Tobago, that day is a holiday. It is the Indian Arrival Day, which is a national holiday. So we had to postpone our meeting from May 30th to June 5th, which is today. We had no thought of abandoning this meeting and this celebration, even in the context of the pandemic and what is happening in Trinidad and Tobago in that regard. Today, we propose to celebrate in honor of the tenacity of many MS patients. We want to raise awareness of MS to the wider population, and we want to bring together caregivers and medical experts and providers of care for us MS patients. Now, I want to go a little bit into the reason for creating MSSF. As president, along with a few other members, we decided that our membership needed support. We needed support in various areas. There were many unmet needs. So we decided to form this organization to do just that, give support to MS patients in these areas. Some of the areas are we needed physiotherapy, massage therapy, information on nutrition. We needed occupational therapy, and so on. So we got professionals together who largely gave these services pro bono for us, for which we have been very, very satisfied and thankful. Particularly our physiotherapist, who is trained in giving physiotherapy to persons with neurological problems, and we're thankful for her. We also formed a body of persons, professionals to support our foundation. We also had need for information and education on MS itself. So we had persons from local and international agencies to come and talk with us. Some came home even to my home where we had meetings and so on. And we had a very important doctor from Costa Rica, Dr. Soto, who talked to us a lot about the process itself, what happens with MS, and some of the new drugs that were available. We had a problem with getting adequate drugs. Some of the drugs we understood became available later, and that was especially for persons with PPMS, that is primary progressive MS, for whom there were no drugs available at all, either locally or internationally. No drugs were developed for PPMS patients. And we realized from Dr. Soto and others that such a drug was available now in this period. And we tried to struggle for getting these drugs to our patients. Indeed, that struggle lasted all of about the last 3 years, backward and forward through the Ministry of Health. And that drug was called Ocrevus in our terms, Ocrevus. And we also found out that it was useful for all MS patients, PPMS, RRMS, that is relapsing remitting MS, as well as SPMS, that is secondary progressive MS. And it is available and useful for all those types of MS. So we are on a mission to get this drug available for our patients. And indeed, in this area, we have not been very successful. We have been promised by the Ministry of Health that this drug would be available at least to the PPMS patients, but that has not yet been realized. Some of our RRMS, and indeed 2 persons in our group, are now on this drug tentatively, and we need to get it firmly available for them. So those are our struggles. Those are what we want to get. And those are some of the ways we tried to bring support to our members. So today we want to celebrate 2 of our members who have been in the struggle. We want to honor their tenacity and their continuation in carrying out this struggle. And one of them is Patricia Williams. She's a mother of 5 children who are all accomplished children. She has had MS since 1991. She is from Venezuela originally, and now she speaks fluent Spanish and English. And her son, Gabriel Williams, is one of the members of our professional committee. So we honor Patricia Williams today for all that she has done. Another person we want to honor today is Zora Fakul. Zora is from Czechoslovakia. She's the mother of 3 girls. She has had MS from 1983, but Zora has struggled and struggled and gone through all she has to do. I think both Zora and Patricia are PPMS patients, and they have been working, bringing up their children and doing so very well as other things. Zora has a diploma in counseling, and she has done a course in graphic design. She's very artistic. She does sewing and drawing, and she's also very interested in nutrition. And she has done a lot of her own research on nutrition that is necessary and useful for MS patients. So these are 2 of the persons we want to honor today. I hope they are here, and welcome and praise them for what they have been doing. We have stories of some of our other members and those stories are published on our website. So thank you very much. This was an introduction, I hope, to what MSSF is about and what we're trying to do. Thank you very much.
Thank you, Dr. Phillips. Thank you for that. Okay, and now we moving things along. I will invite Dr. Avidesh Panday, consultant neurologist and representative of the Ministry of Health, to give an address.
Thank you very much, Saran, and to the president of the MSFTT, Dr. Daphne Phillips, members of the executive of the MSFTT, Dr. Nicholas Maraj, consultant at the Eric Williams Medical Sciences Complex, and to all of our attendees this morning. A pleasant morning to everyone, and I hope everyone is staying safe during these trying times. Thank you for granting me the honor of addressing you today, and the Honorable Minister of Health regrets that he's unable to attend this meeting. But I've been tasked, and it's my pleasure to bring greetings on his behalf and that of the Ministry of Health. It's a bit challenging because I am a bit on both sides in that I also have access to clinical care and I provide clinical care. So it's a new role and it's a bit of duality. But we at the Ministry of Health, we consider ourselves very fortunate to partner with an organization such as the MSFTT, which has been doing long-standing, fantastic, and dedicated service to the patients with multiple sclerosis, from education to empowerment to advocacy. And it's also it's my pleasure to be able to speak to you on World MS Day 2021, which is being celebrated under the theme of connections. Our role at the Ministry of Health is to reduce the invisible but formidable barriers that leave many patients with multiple sclerosis sometimes fighting a lonesome battle without community support, and in some instances, unable to access healthcare of varying spectrums, whether it be therapeutics, physical therapy, mental health counseling. This is something that we've been working on, and we will continue to work with in partnership with advocacy groups such as the MSFTT. Just a bit of overview on the technical side of things. And even though notes have been prepared for me, this part is second nature to me, being a doctor. As we know, and Dr. Maraj will speak more about this on the technical side. As we know, multiple sclerosis is a complex, very unpredictable, as Dr. Phillips said, sometimes relapsing, remitting, some patients progressive, neurological problem that causes damage to the central nervous system. And it's a very large spectrum. You have some patients who may have mild symptoms such as sensory disturbance in a limb, to some patients that have severe symptoms, inclusive of loss of vision, as well as even in some patients, paralysis. And as Dr. Phillips said, in some instances, progressive accumulation of injury within the central nervous system. Many patients can go on to have a good quality of life for a long period, but some persons go on to accrue progressive disability, and this brings us to the continuum and the range of multiple sclerosis. Worldwide, about 2.5 million persons are affected with it. And while the prevalence of multiple sclerosis is higher in temperate countries, we do have some patients in the equatorial countries, such as Trinidad, where with multiple sclerosis, and the prevalence is about 10 per 100,000. And we have databases which would show that there are about just north of 200 persons affected with multiple sclerosis in our population. On the backdrop of this, given this population, the effects that it may have on the patient, the family, the extended family, the caregivers, We wanted to provide a platform for persons living with multiple sclerosis to share their experiences and potentially give us feedback in how we can improve our services at the Ministry of Health. And one avenue of this is through foundations such as this. So again, we congratulate you on a job well done. While we are celebrating World MS Day with the primary aim of bringing awareness, connectivity amongst patients and caregivers, as well as connectivity amongst patients, caregivers, as well as other aspects of medical care, such as mental health, physical therapy, and allied other medical personnel. We must acknowledge the role of the caregivers. We must acknowledge that MS does not only affect patients, but it affects everyone. And we must work harder and we must do better to improve support for everyone affected and touched by this illness. Some of the work that has been happening behind the scenes at the Ministry of Health level would be expanding our services as well as improving the access to medical care amongst all of the RHAs through the various neurology clinics. But while we will do our part, and I'll touch on that a little bit later, it is also important that the population and the support groups continue to do their part. As citizens of Trinidad and Tobago, we must not turn a blind eye to our families, to our neighbors, to our members of the community. We must help, we must engage. From a simple phone call to asking how you're doing, to seeing someone having some troubles getting out of the car, assist. We must encourage persons to volunteer their time and their efforts and resources to groups such as the MSFTT. But most importantly, we must be our brother's keeper. At this moment, we cannot speak of anything related to health and not speak about COVID-19. COVID-19 has had an impact not only on the general population worldwide, but obviously it would have an impact on patients with multiple sclerosis. Speaking now not as a representative of the Ministry of Health, but as a doctor, I had the pleasure of speaking with many of you last week, Saturday, when we discussed the ramifications of multiple sclerosis and COVID-19. And I will not touch more about it too much because I'm sure Dr. Maraj may be able to field questions about it. But I must remind members of the MS community that, and reference could be made to the United States National MS Society guidelines, the Australian guidelines, the English guidelines. Patients with MS are not more prone to getting COVID-19. But should you get COVID-19, your risk of developing severe COVID is much higher. This is because, and this is more in keeping with the vulnerable populations of MS, that includes progressive MS, patients with significant disability and reduced mobility, men, male sex, as well as patients with MS and other comorbidities such as diabetes, heart and lung disease, obesity, and of course, that cohort of patients on disease-modifying or immunomodulatory treatment. This population, should you get COVID, is at a higher risk, and should you be worried about your symptoms, do not hesitate to contact your agencies, your respective local agencies of healthcare. We must also touch on the mental health aspect of things. As citizens, as people, as persons with MS, it is very important to pay attention to your physical and your emotional well-being, or your mental wellness, as we say. Within the confinements of the law and the regulations set by the Commissioner of Police, and abiding by all protocols of safety, we must make time for physical exercise, whether in your yard, in your house. Speaking now as Dr. Avidesh Panday and not as a representative of the Ministry of Health, I would have spoken last week and told patients if you have a home where you have stairs and you're able to walk up and down, walk up and down, take a walk around, stretch, do something physical. If you have friends and so on with this condition or not, connect with them via phone, electronically via Zoom, engage in conversation, keep your mental wellness at the forefront of your struggles. And of course, make time to exercise within the confinements of the law. What is the role of the ministry? What is the role of the Ministry of Health in treatment? As mentioned earlier, one of the things that we have been doing is that we've been improving our capacity to treat patients with multiple sclerosis countrywide. Southwest Regional Health Authority, Northwest Regional Health Authority, the North Central Regional Health Authority, and by extension, the Eastern Regional Health Authority, all have neurology clinics. All of these clinics are outfitted with neurologists, but we are working to provide and recruit more neurologists to increase care for our patients. We've also been making a lot of headway, as Dr. Phillips alluded to, with the availability of relevant pharmaceuticals, inclusive of disease-modifying treatment, as well as other medications, inclusive of pain medications, as well as medications related to mental health. We were guided by the landmark study done by Dr. Azad Ishaq, who is a pioneer of multiple sclerosis treatment in this country and has done quite a lot, inclusive of his academic publications. And I quote from his paper published in the Caribbean Medical Journal, Multiple Sclerosis in Trinidad and Tobago, where he highlighted that patients in Trinidad had more disease activity, a higher disease burden, more disability, and medications such as interferon were not as efficacious as data from more temperate northern countries. And based on his work and his data, we have been able to expand our treatment options for patients. And we now have readily available medications such as fingolimod, as well as rituximab. Dr. Maraj was recently able to chair a meeting where we discussed ocrelizumab, and in due course, we will discuss that at another time. So in conclusion, I would like to salute the executive of the MSFTT for a wonderful job. I hope, and it is my wish, that you grow and we continue to work together to improve the quality, care, and overall wellness of our population of patients with multiple sclerosis, as well as for their family members and caregivers. I thank you once again, and I look forward, or the Ministry of Health looks forward to working in partnership. We will see you again at World MS Day 2022. Thank you very much.
Thank you, Dr. Panday. Thank you. All right, and right along to our featured presenter, Dr. Nicholas Maraj.
Hi, good morning, everyone. To the members of the MSSF executive, a pleasant good morning. Special morning to Dr. Avidesh Panday, who is my esteemed colleague at Eric Williams Medical Sciences, as well as probably the most avid MS physician in the country at this point in time. Welcome to all the patients with MS who are with us right now, and welcome to everyone else. Good morning. So I'm going to screen share my, I'm very pleased to be given the opportunity to provide the special presentation this morning on the, in auspices of World MS Day 2021. And what we're going to do is we're going to be speaking a little bit about MS and COVID. So I am going to screen share my presentation with you guys now. So, okay, so World MS Day 2021. The objectives of this presentation will be to just have a little overview of what MS is. I'll speak a little bit about the treatments of MS in Trinidad and Tobago, have a specific chat about COVID infections and MS, and speak a bit about COVID vaccinations and MS. What is MS? MS is a chronic inflammatory demyelinating disease of the central nervous system, characterized by ongoing disease activity with profound effects on patient independence and quality of life. There are approximately more than 2.5 million people suffering with MS worldwide, and it has no cure, but several treatment options are available. The disease course is unpredictable, leading to a 5 to 7 year decrease in life expectancy. There's a decrease in cognitive function in about 43 to 65% of patients, and MS by nature of the disease often results in disability, with the median time for patients requiring some aid to mobility being about 18 years. MS is not a simple one type of disease, which makes it very difficult to manage. The spectrum of this disease ranges from the clinically isolated syndrome to the relapsing remitting form, which is which about 85% of patients have, characterized by acute relapses with full or partial recovery in between and stable disease progression during that point in time. Then there's the progressive forms of MS, secondary progressive, which starts off as relapsing remitting, and then there's progressive accrual of disability over the progression of the disease. And then there's the primary progressive form of MS, which accounts for about 10 to 20% of all patients with MS, where there's disease progression from the onset of the disease with no specific relapses with recovery. All forms of MS can also be categorized as either active or not active. As Dr. Pandey alluded, the MS symptoms are variable and unpredictable, and there's a range of spectrum of disease disorder. The most common MS symptoms are fatigue, which is present in about 80% of MS patients, pain, sensory issues such as visual disturbances, numbness, tingling, mobility impairment and muscle weakness, which is one of the major contributors to the disease, spasticity. A little bit of less common symptoms include speaking problems, seizures, hearing loss, breathing problems. And then the secondary or tertiary symptoms of the disease itself, such as urinary tract infections, decreased bone density from having issues with your spinal cord problems itself, and then the social, vocational, and psychological complications, which are the compounders of the disease. A big important part also is progressive cognitive impairment in patients with MS. One of the major problems with MS is that the disease burden is compounded by the age of the patients who usually get MS. MS is typically common between the 21 to 40 age range, which leads to a significant contributions on the workforce, quality of life, and medical expenditure. Compared to non-MS patients, MS patients have a 3.5 times increased risk of unemployment, a decrease of approximately 10 years of quality of life years, and a 5.1 times higher increased direct medical care costs versus their non-MS counterparts. The major treatment that we have for MS is known as disease-modifying therapy. And the goals for that treatment is to reduce the rate of relapses, slow the disease progression, and reduce the formation of new lesions on MRI, which are all markers of disease progression. So just to allude back to MS in Trinidad and Tobago, as Dr. Panday said, we have approximately 200 patients in Trinidad and Tobago with MS. For those patients, I just accrued this information from just speaking to my colleagues in San Fernando, Port of Spain, and Dr. Panday and Eric Williams. The amount of patients who are currently undergoing treatment for MS in San Fernando is approximately 14, 12 on beta interferon, 1 on rituximab, 1 on ocrelizumab. Port of Spain general, approximately 23 patients on treatment, 10 on fingolimod, 10 on beta interferon, 3 on rituximab. And at Eric Williams, it's approximately 107 patients with 31 on beta interferon, 25 on fingolimod, rituximab about 48, and ocrelizumab 3. Just to highlight the treatment, why we have much more patients with MS at Eric Williams is, as Dr. Panday alluded to, Dr. Isak, who practiced at Eric Williams before, was the major thrust driver for MS research and accrued a very large number of MS patients during his tenure as a consultant here over his 20 plus years. Needless to say, Dr. Panday has also, in his very short period of time here, managed to have at least 50 to 60 plus patients with MS and has been a really pivotal driving force in managing to put patients on significantly more effective disease-modifying therapies, such as the monoclonal antibodies, which specifically most of those rituximab patients being his. Now, I just want to speak about the elephant in the room, COVID-19 and MS. We'll just speak a little bit about what is COVID-19, not that anybody doesn't know right now. It's a respiratory infection caused by the virus SARS-CoV-2, which was discovered after an outbreak in Wuhan, China in December 2019. The SARS-CoV-2 is a type of coronavirus, which is a large family of viruses that cause illnesses from the common cold to more severe infections in humans. COVID-19 causes a variety of symptoms in people who are infected. Not all people infected have the same types of symptoms. The most common symptoms vary from fever, dry cough, shortness of breath, fatigue, body aches. Some patients will also experience headaches, abdominal pain, diarrhea, sore throat, and these symptoms typically appear 2 to 14 days after exposure, although some can have symptoms not up until 24 days after. Oops. So just going back to COVID-19 infections and MS, and this bit of information was taken from the Journal of MS and Related Diseases, January 2021, which was a systematic review of COVID-19 and disease-modifying therapies in patients with demyelinating diseases of the CNS. Now, in the setting of COVID-19, some early studies have reported a rate of hospitalization that was higher among patients with MS than the general population, and that MS patients on B-cell depleting therapies had increased risk of SARS-CoV-2 infection or had a worse clinical outcome. However, other studies after these initial studies could not confirm these observations. And furthermore, it appears that most MS patients with COVID-19 do not require hospitalizations despite being on disease-modifying therapy. Moreover, most current data do not support an increased risk of worse outcomes related to disease-modifying therapies, reinforcing the recommendation of not stopping MS treatment in these patients. The risk of mortality of COVID-19 in MS patients appears similar to what is seen in the non-MS population. However, as Dr. Panday said, there is a relatively higher mortality among patients on anti-CD20 therapies, and most of the patients who died from COVID-19 complications appear to have multiple comorbidities and higher EDSS, which is the MS severity score. The overall COVID-19 outcome was favorable in patients with MS receiving disease-modifying therapy. However, it is still highly recommended that all MS patients undertake personal protective measures to reduce the risk of COVID infection, particularly when immunocompromised. Now, this just so we're going into a bit on preventing COVID infection. As we all know right now, one of the major thrusts is social distancing and wearing of protective face masks. And which has been on the hotbed of the national furor these days, the COVID-19 vaccines. Just to put things into a bit of perspective, the world population is about 7.8 billion people, and the number of confirmed COVID-19 cases as up until last night was approximately 172 million, which is approximately 2.2% of the entire world population. And out of the 172 million COVID positive patients, we've had approximately 3,700,000 deaths related to COVID-19, which accounts for approximately 2.15% of all the COVID-19 cases. Something to note is that the true number of cases is likely higher due to differences in testing between countries and the number of asymptomatic or mild cases that go on to be unreported. In order to gain herd immunity, we need to achieve a threshold of vaccination of approximately 50 to 70% of the world population. So just looking at the disease-modifying therapies and their effects on our immune system, specifically, we're going to highlight beta interferon, the S1P modulators, of which fingolimod is a part, and ocrelizumab and rituximab, which are part of the same family of medications. Beta interferon modulates B cell and T cell activity and cytokines. Fingolimod progresses the egress of the T cells from the lymph nodes, and ocrelizumab and rituximab are anti-CD20 medications that deplete B cells. Beta interferon, possible impact on the vaccine is that it's unlikely to impact protein or inactivated vaccines, and there's an unknown compatibility with live vaccines. S1P modulators and monoclonal antibodies, these may reduce an immune response in protein or inactivated vaccines, and they are incompatible with live vaccines. The COVID-19 vaccines target the coronavirus spike proteins, which are responsible for the binding to the ACE2 receptor on the host cell membrane, which is the first step in the viral invasion of the SARS-CoV-2 within the host cell. By forming antibodies against the spike protein, we can try to prevent the first step of this entire viral invasion into the cell and hence prevent COVID-19 infection into vaccinated individuals. Our vaccination programs are two-pronged. It's really considered at a population level. The aim of vaccination is to protect the population from the disease by providing a level of herd immunity, and vaccines need to be both safe and highly effective, with a majority of the population being vaccinated in order to achieve herd immunity. The goal of the therapy is for safety for all, and MS treatment is considered at an individual level versus a population level, where we consider the individual who's being vaccinated, where a disease-modifying therapy delay or switch may be required in order to receive the vaccine or to improve vaccine efficacy. This may impact people with MS's safety and exacerbate their disease progression. Hence, care decisions should be individualized on different people with MS. One of the major issues is the timing of the SARS-CoV-2 vaccine. Ideally, the vaccine administration should be precisely timed in people with MS to ensure the optimum level of vaccine efficacy. However, SARS-CoV vaccines are in finite supply. Choosing a specific timing of the vaccine administration is not necessarily feasible in the real world. And there are also constraints with respect to personnel administering the vaccines and lack of walk-in options. That means whilst vaccines should be ideally timed in people with MS receiving disease-modifying therapy, some level of immune protection is still beneficial where the luxury of timing administration is not ideal. So this involves a level of shared decision-making where we have a risk-to-benefit ratio of the risks of delaying a patient's treatment with their disease-modifying therapy versus the risk of the patient having COVID-19. If the risk of MS worsening outweighs or is equal to the risk of COVID-19, the disease-modifying therapy schedule should not be altered, and the patient should be fully vaccinated as possible. This is guidance from the National MS Society. So the safety and effectiveness of the COVID vaccines in people living with MS, the sources of evidence that were used for these types of recommendations is the general population of the people studied in the vaccine trials. Unfortunately, people with MS were largely excluded from the phase 1 clinical trials, and the number of people with MS participating in phase 2 and phase 3 trials is not known. We've extrapolated from studies of other vaccines administered to people with MS, for example, the VELOS trial, which evaluated ocrelizumab in patients who received the pneumococcal vaccine and influenza vaccines, and basing things on immunological principles, such as the immune response to vaccines, both the humoral and cellular, the biology of MS, and immune therapies related in MS therapies. Now, national and international groups of expert researchers and medical professionals agree that people with relapsing and progressive forms of MS should be vaccinated against COVID. These include those patients who have recovered from COVID-19, and especially those in the high-risk groups, especially as Dr. Pandey had pointed out, patients with progressive MS, patients who are older, who have a high level of physical disability, those with certain medical conditions such as diabetes, high blood pressure, obesity, heart and lung diseases, pregnancy, and patients who are Black and Hispanic populations. This would apply mostly to the US populations. And guidance is continuously evolving in response to new information that is made available. The safety of the COVID-19 vaccines in people with MS, the available vaccines do not contain live virus and will not cause COVID-19. That's important to highlight. Vaccination is not likely to trigger an MS relapse or have any impact on local disease progression. In a study done in Israel between December 2020 and January 25th, 2021, the relapse rate on patients who received vaccinations with the BioNTech vaccine was 2.1% relapse rate after the first dose of the vaccine and 1.6% after the second dose. Of note, vaccine-related fever may worsen patients' symptoms temporarily, which might resemble a pseudo-relapse. In general, the risk of COVID-19 outweigh any potential risks from vaccination. An important point is a recommendation for timing of COVID-19 vaccines with MS. When the MS is stable, patients who receive the following DMTs should be fully vaccinated as soon as possible, as soon as they have access to the vaccines. And for us specifically here, the patients who are on beta interferon should have the disease-modifying therapy, should have the vaccine as soon as possible. For patients stating or receiving other therapies, adjustments may enhance the vaccine effectiveness. However, prompt vaccination may be more important than coordinating timing with therapy changing, and decisions should be made on an individualized basis. Specifically, what I'm going to go through here for optimized vaccine response is the S1P receptor modulators, fingolimod, and the anti-CD20 monoclonal antibodies, rituximab and ocrelizumab. For fingolimod, the timing of fully vaccination for patients before they start therapy, patients should be vaccinated 2 to 4 weeks or more before they start fingolimod, or once they're receiving fingolimod concurrently, they should be vaccinated as soon as the vaccine is available. For patients on rituximab, for patients who are about to start rituximab or ocrelizumab, they should be vaccinated 2 to 4 weeks or more before they start their infusions. And on patients who are currently on treatment, 12 or more weeks should have elapsed since their last dose, and there should be 4 or more weeks before their next dosage of infusion. Specifically for patients who are having an acute relapse and need corticosteroids, the inactivated and non-live vaccines may be given during treatment with high-dose corticosteroids. However, the immune response may be attenuated, and your recommendation is at least 3 to 5 days after the last dose of corticosteroids when the patient should be vaccinated. So most of that was from the National MS Society, just a little bit from the Association of British Neurologists. All COVID-19 vaccines are safe for neurology patients. The ABN recommends that you take whichever vaccine that you are afforded without delay, regardless of your age, state of health, or medication you're receiving, unless a specific contraindication is applied, such as severe allergies. And the Multiple Sclerosis International Foundation, the National MS Society, and the Canadian Network of MS Clinics in January of 2021 for MS patients. They should continue their disease-modifying therapy unless they're advised by their MS healthcare provider to stop or delay it. Stopping some of the disease-modifying therapy can abruptly can cause severe worsening of the MS itself. And based on the data from previous studies of other vaccines and DMTs, getting an mRNA vaccine whilst on any DMT is safe. Some DMTs make the vaccine less effective, but it would still provide some protection against COVID-19. For those taking ocrelizumab or rituximab specifically, you may need to coordinate the timing of your vaccine with the timing of your next DMT dose, as we previously stated. And it's important to work with your MS healthcare professionals to determine the best schedule for the patient. Just to recap the key points again, whilst they're concerned over vaccine efficacy with immunosuppression therapy, we must not forget that the ultimate goal is to prevent disease progression. Whilst there are no set guidelines to follow, healthcare practitioners are reliant on real-world experience and guidance from the organizations. As we have previously heard, the clinical practicality of switching or delaying therapy must be carefully considered in patients' regards to disease progression, safety monitoring, and the risk of severe COVID. And each patient must be considered on a case-by-case basis, carefully assessing the risk of suboptimal MS management versus the risk of suboptimal vaccine efficacy. That concludes my presentation. Thank you very much for your kind time.
Thank you so much. Thank you so much for that thorough and conclusive presentation, Dr. Maraj. We're going to have a question and answer segment. So I invite anyone with a question to raise your emoji hand. If you look at the bottom of your screen, you should see something called reactions. Yeah, and you can click it and raise your hand if you have a question. We have Laura.
Good morning. Thanks for having me here, Saron. I just want to know, how does one know that they have MS? What are the symptoms that would make somebody decide to be diagnosed? Because I was listening to the common symptoms and they sound like it could be anything. So how would you know to ask specifically for a diagnosis for MS?
All right, sir, thanks very much for that question. Yes, the spectrum of disease for MS is very wide-ranging. Usually, patients present with acute focal neurological symptoms, for example, loss of sight in one eye, reduced visual acuity, maybe tingling, numbness in the feet, or loss of muscle control of one part of the body, coordination difficulties, or changes in their speech. Much of the symptoms I've highlighted, for example, the cognitive dysfunction, fatigue, sensory abnormalities, usually happen with progressive disease of MS. Most patients who have MS usually start having an acute attack response, and based on one of the clinical scenarios. And based on that, patients will then present to a healthcare provider who will do the necessary workup, which would include an MRI of the brain to look for plaques, which are specific and suggestive of events in the brain and increases the risk of providing a confirmatory diagnosis of MS. Dr. Pandey, do you want to answer?
No, I will defer all technical questions to you.
Thank you.
Okay. Jillian Rodolfo, you have a question?
Good morning, everyone.
Good morning.
My question for Dr. Maraj is, I noticed that the information you shared was on the number of MS patients was specific for Port of Spain, San Fernando, and Eric Williams, and no information was provided about Sandy Grande, which I am a patient, I am a part of the clinic, the neurology clinic in Sandy Grande. You have information on it, please?
Hi, thanks for that question. Lamentably, I was not provided with any information from the practitioners at the neurologists at Sangre Grande on the number of patients who are on disease-modifying therapy or the number of patients who have MS in Sangre Grande. So that's why I couldn't provide any information.
Is there anyone else with a question? Or a comment? Story to share? Just raise your emoji hand in the reactions tab. Yes. Hasina. Yes, Hasina.
Good morning from Fort Lauderdale, Florida, in the United States of America. I just want to thank you, Dr. Phillips, for having this type of forum, which is very important because, as we know, knowledge and education is most important, especially that I live here and you guys are over there dealing with COVID and multiple sclerosis, as I am too. I know a lot of things that people might listen to on the world news that you get in Trinidad, that Florida has all these challenges and things like that. But what I did hear is what the minister said in regards to we have to do the protocols, such as washing hands and making sure we have space between each other and things like that. I'm just maybe here to kind of bust some of those thoughts of, okay, Florida or America is going through all these things where that's not really the case. The news will say one thing, might not always be the same. I also have a friend of mine that has PPMS. She also had COVID. She just had a cold. And of course, nobody is the same. And what I always wondered, because how I think MS came on for me, and also my older brother that is my half brother, we both were diagnosed at 31. We always had a thought of maybe it was where we grew up, where they had a chemical spill. Or I guess now knowing that he is my half brother, maybe it's something that's hereditary. What understanding could you give myself and everyone on here that is diagnosed? Because I think that's the challenge. I was very surprised to even know how much the Republic of Trinidad and Tobago is affected because of, first of all, they say if you live in the north, if you live in the cold, it's worse. Trinidad is a Caribbean tropical area. They talk about the magnetism and things like that, and the health is not so bad. So please share more where I can have an understanding of where is this really coming from? And also sometimes how it is misdiagnosed, as somebody asked previously too, in regards to the symptoms. My brother and I don't have the same symptoms. He had one acute attack, that was it. He takes no medication, he doesn't get MRIs, he doesn't do anything. In regards to myself, that's not the case. I've had a lot of symptoms and have been on many meds that you guys have been on, but now I'm on to Sabri. Whoever wants to share or give me an
All right, Hasina, thank you very much for talking to us from Florida there. So I'll take your questions piece by piece. So I'm guessing you're asking a bit about what are the risk factors for MS. And historically, we've been told that MS is more a disease of Caucasian population, and people who live more in the northern territories. That has been associated with what we believe is decreased exposure to vitamin D in those patients living in the northern territories, and a specific treatment for some patients who have MS in the more Scandinavian countries or temperate climates is vitamin D therapy itself. With respect to the other risk factors for MS, there is some research going on to whether there is a specific environmental component to it, specifically exposure to a virus called the Epstein-Barr virus during some point of time during your life. There is also a specific connection with cigarette smoking and increased connection with obesity. Those things tend to make MS worse. Now, between you and your brother having different types of or different disease severities of MS, that basically goes back to stating the realm and the inhomogeneity of the disease. There is some genetic link to it. That genetic link has not been fully elucidated. However, there is a genetic component to MS. The fact that you have more severe MS than your brother could be due to a lot of different environmental factors, such as maybe some sort of occupational exposures, maybe exposure to the Epstein-Barr virus in the past, or certain things that we're not completely fully understood of yet at this point in time. Hope that answers your question.
I think the challenge again is that, or maybe it's not stated, and I'm sure it happens in other immuno illnesses or diseases, is the stress factor. When I speak to colleagues, friends, now that I have, that have been diagnosed with multiple sclerosis, everybody can recall a time in the past where they had challenges with stress. And maybe you could talk about that aspect.
Stress itself is a known, so stress itself is a very esoteric term. Everybody knows that stress significantly contributes to many negative problems with neurological disease. Some people believe it might be due to the increased production of cortisol as the stress hormone, which might be responsible for reducing your immune system's functioning. The other thing with MS, stress and fatigue significantly affect your current level of disability by making the actual transmission of nerve impulses less good around the areas where you've had demyelinating plaques. So if you've had maybe an episode of optic neuritis where you've had visual difficulties in maybe one eye, any sort of stress or fatigue or fever type symptoms could cause recurrence of your symptoms transiently.
That's funny. That's how it started with me, optic neuritis. Yeah, I think maybe or believe that most people on here would agree stress played a part, or you noticed that you had some type of stress episode and then you were diagnosed. That's all. That's all I have to say.
Thank you very much.
Thank you, Hasina. Anyone else with a question, a comment? We will close the floor soon. Yes, I'm seeing a hand. Yes. Hi, Gabriel. How are
Hi,
you?
good morning, everyone. Good morning, brothers and sisters. Good morning, Dr. Phillips, for organizing this event on this auspicious time. I really, really appreciate it. Good morning to the doctors that did the presentation. It was very, very, very informative. Thank you very much, Dr. Pandey and Dr. Maraj. My question is, it's a, it's just a, it's a question that I've been thinking about, Dr. Maraj. In terms of, I know you are very much involved on the treatment end. But my question, I don't know if you could provide some insight, has to do with the journey to finding a cure. I know you've went into detail of the different types of treatments, but here it is. We all know, we all know the battle that we're facing as the human race to get to the bottom of COVID-19 and to find that everybody's doing vaccine trials, everybody's doing vaccine treatment and whatnot. But specifically to MS, in your mind, or at least what you know in the medical world, where's that timeline to get to a point where we understand the virus, sorry, not the virus, the multiple sclerosis, and we have some sort of resolution? I mean, that's my question. Where are we in terms of getting to the bottom, getting to the end of this as something among us, the multiple sclerosis? Sorry about that. I have children in your background. That's it. Thank you very much.
That's okay. Thanks very much, Gabriel, for that question. That's a very good question indeed. Now research is going on by many centers throughout the world to identify things that are important in MS, such as the neurofilaments, what contributes to the initial demyelination, what contributes to further plaque formation. More research is being done to find out the epidemiology of the disease, why maybe some of the environmental factors are responsible, why some of the genetic factors are responsible. To give you an idea about a timeline for a cure itself, I mean, I really can't say, but I can say that over the past about 25 years, we've gone from just having one disease modifying therapy in the form of beta interferon alone to getting glatiramer, to getting teriflunomide, DMTs, to getting the S1P inhibitors, to getting all the monoclonal antibodies, to even newer medication. We used to have medication that was only injectable before, to now getting medication that you can take orally. And in the space of 20 years, we've done a remarkable amount in terms of treatment and research. And I'm thinking that we'll definitely continue moving via leaps and bounds over the next couple of years. And we all remain hopeful that as we further unearth the mechanisms surrounding the identification and the progression of MS, we can one day come to providing a cure and maybe even prevention of any sort of MS disability or prevention of getting MS in total. Hope that answers your question.
Okay, we will take one more question from Hasina, and then we will wrap things up. Yes, Hasina.
Okay. My other thought for Trinidad, because that is my second home, I'm also a citizen of Trinidad and Tobago. When are you going to be able to, as a government, get the other therapies there? Because it's so needed. What is the process of how you get the other drugs there in Trinidad and Tobago? I've been on to Sabri for maybe 6 years. I have tried Gilenya. I think that's one of them that are on your list. I have tried another one that you used to have to take 3 times a week, or everyday Capoxin. I know you use different words. It's kind of like the way we are with cars. You know about the Toyotas, but you might call a Toyota, we might say Versa, and you might call it something else. How can we get these drugs that we have here in America to Trinidad? What is the process?
I guess that question is for me. Well, first of all, over the past 20 years, you've seen an expansion in the amount of medications. Different medications have different mechanisms of action. So for example, you may have one drug which acts at certain level, as Nicholas would have shown you in his presentation. So you have to break it up not into the quantity of drugs, but into the mechanism of action. Now, when you start treatment for multiple sclerosis, there are different schools of thought. For example, there is escalation treatment, whereby you start with, in your instance, you started with the injections, and then you graduated going up into the Gilenya, which would have been a little bit more efficacious. And now you're on to Tysabri, which is an infusion-based medication, which is a bit more efficacious. So your doctor, your physician would have treated you in a way whereby they probably would not have been happy with the response you had to medication or treatment A, and then you would have gone forward. So that would be called the escalation method of treatment. Then there are persons, because of the knowledge that we have, whereby you can spot certain red flags, meaning that this person is at a very high risk of accruing disability or moving into lots of attacks very quickly. So you would probably want to try a more efficacious medication and get your disease state under stability. And then with time, you can de-escalate. So whichever approach you take, you need to have medications which would be able to put you along whichever pathway. So the question is not how many medications should we have, but how many different classes and types of medication. We have gone in the space of 3 years from just having one treatment, which is interferon, to having 3 medications across 3 different classes. And it's a very good accomplishment because you have now the facilitation of patients via the escalation treatment, and you have via the de-escalation treatment. We are moving towards evidence-based medicine, whereby just because a medication is licensed for a certain indication in the US doesn't mean elsewhere around the world, such as in Europe, in England, that medication can't be used as well. So what we have to factor in the equation is, one, do we have medications for all types of populations? And Dr. Phillips makes an important point about progressive MS, and that is in the pipeline. And it's very near to completion. So one of the other things that we are working towards doing is having a protocol-driven system whereby it will be used as a tool to the treating physician, whereby there's a national framework, meaning if you fulfill this criteria based on the amount of white matter lesions you see on the MRI, how many attacks you have, we can use a national document for policy, as in you use treatment X, Y, and Z. It is by no means the be all and end all or the definitive way to treat, but it is to be used as an adjunct. So where we are, where we have been, and where we are going, certainly it's a very good place, but I don't think that we will be, I do not speak as, I speak here now as a senior neurologist with experience in MS here. I think the key is to get a large amount of different type of medications with different mechanisms of action, rather than stockpiling the same thing over and over. That way you can reach more patients One of the other things too is side effect profile. So if you have a side effect to medication A, you have a second option. So in summary, to just bring clarity to your question, how are we going to move towards that? One, we're going to expand our armamentarium, but we're going to do that in a logical, stepwise, and in a national policy framework. And if more publications come out, like the work Dr. Isak would have done, I was also involved in a publication, we are using that to build on. I hope that answers your question.
Thank you. Thank you so much for that, Dr. Panday. It is time for us to wrap up the meeting. Just like to especially thank Dr. Panday and Dr. Maraj for their contributions. I know I learned a lot in this meeting. I'm sure we all did. And there's two things I would like to mention before we leave. The recording of this meeting will be uploaded to the Foundation's YouTube channel. And so you simply can go on YouTube and search for the Multiple Sclerosis Support Foundation. And then you can see a recording of this meeting. And feel free to subscribe to the channel as well, as we'll be posting videos from time to time. In the spirit of camaraderie, I'd like everyone to put on their cameras so we can get a screenshot of the meeting. So I encourage you all, put on your cameras, give a nice wave and a nice smile. Yes, yes, I'm seeing the cameras turning on. Yes, yes. Almost there, almost there. Hi, Jillian. Hi, Stacy. Hi, Dominique. Hasina, Gabriel, Roland, Janelle. I had the pleasure of speaking with many of you since I've been involved. Roxanne, Tony, Otis. All right. So a little bit for persons to put on their cameras. I'm gonna get a nice full screenshot. Yeah. Janelle and baby. Patricia, I see you. Amrita. All right. Can we together? Great. Fantastic. Thank you so much, guys. It was indeed a pleasure. And we have to wrap things up now. And just reminding you as well, with the whole COVID-19 pandemic that's going on, the 3Ws, wear your mask, watch your distance, wash your hands, and God be with you.
Thank you very much. Have a good day, everyone.